The second half of the year was, I guess it kicked off with ESMO.
Yeah. Where do you want to start in ESMO?
I think...
Want to start with kidney cancer?
No. I'm going to start with prostate cancer.
Okay.
I'd like...
P3?
I'd like, Silky Gillison, presidential session, investigator-initiated trial.
Yep.
P3, spectacular. Talk about P3 for me.
So P3 was in a metastatic CRPC setting in which most patients, 97%, hadn't gotten prior ARPI. I think 2 or 3% got prior ABI, just the timing of the trial, of course. Enza plus minus radium. So you'll remember radium, this bone-targeting radiopharmaceutical, approved based on the Alsimca trial years ago. Wasn't really getting much clinical use, wasn't getting the love, even though there was an overall survival benefit. I've used it. I think when the Vision and other data came out, just like it wasn't as sexy as some of the other radioligands. And so this, again, as you mentioned, investigator-initiated trial, Enza plus minus radium, showed both an RPFS and OS advantage with, I think, an identical hazard ratio of 0.69, I believe, and actually a wider median for the OS, which is in the, I think, 3-4 year range. So it was, I think radium continues to surprise and says it's still a very good drug. How this is going to be clinically applied, I think, is the question. Silky on our podcast has been very much like, well, you should only use it in patients who got, just ADT up front, which in the US isn't very many at all. Probably more so around the world, but in the US it's vanishingly few, I would suspect. So we'll see how the implementation is, but really important that, again, as you move active drugs earlier, you can achieve the survival signal.
I was walking in the park when Silky gave me a ring and we talked about this data. And there were two immediate things that struck me. The first is I wasn't...
Number one, why am I walking in the park?
Well, yes. I like walking in the park. I do it quite a lot. But yes, why am I walking in the park in the middle of the night? No, by myself. No, what I thought firstly was I wasn't expecting that.
Yeah, for sure.
Because actually, when you look at lutetium earlier in the disease, it's not achieved survival signals.
Correct.
We'll talk about that in a second. And I think many people, including myself, and by the way, I was wrong about Charted as well. I sat in a bar in Argentina with Chris Sweeney, and we were sitting there. We'd been in an advisory board, and I think he knew the results and he couldn't tell me.
Oh, really?
Yeah, and he said, and we'd just been in the advisory board, and people said, what would the results of Charted like to be? And I said, I don't think chemotherapy is going to work up front. I really don't. And I remember Chris, and actually David Kuhn was there as well. And David smiled at me, and I thought, I've got this really wrong, haven't I, David? And Chris said, Tom, if I were you, I wouldn't talk about your opinion too much. I'm not going to tell you the result of the trial, but I wouldn't talk about it too much.
That's funny.
And the same, I've done the same with Silky, and I thought, amazing, 0.68 OS, fabulous result. And I felt that it opened up radium again, and you'll know, this of course, is when you get momentum behind a new group of drugs, that group tends to go faster and faster, and there are more trials, more emotional, more scientific investment. And so I think it was a really important study. And although you might say it's not clinically applicable from a global perspective because the standard therapy in the frontline settings changed, I actually agree with you. I think it reinforces its drugs having a major role to play. And actually, when you look from the back of the room and think, how does this compare with the lutetium data? I think your two studies with OS is quite impressive. Isn't it?
And whether they can be used sequentially, et cetera, I don't know that we have great data. I think, if I remember correctly, there was one of the subset analysis of Vision of patients who stayed on their ARPI, and I don't remember the numbers, showed a better outcome. Again, subset analysis and all that, but this sort of reinforces that maybe there is something to these two different mechanisms together, right? I mean, these data, I think, certainly prove that, right? It's not a subset analysis. So again, I think it'll be interesting to see how the regulatory agencies look at these data and moreover, how it's used in clinical practice, but there's clearly a role.
At the Uromigos Cup, in the final, we had a question about the Aranote trial, the darolutamide trial, the frontline darolutamide trial. Petros, I think, was a bit
quick on the buzzer
on the question, and I think put the Japanese team at a disadvantage because I could see they were itching to answer the darolutamide question. We've had quite a few studies in this setting. Many people feel darolutamide is the best tolerated drug. Some people were, concerned at this initial analysis it hadn't achieved OS. Mm-hmm. The enzalutamide study did achieve OS, but actually the first interim analysis, we talked about this at our meeting, the Enza study didn't achieve OS. They both had a hazard ratio of 0.81,
right.
And the PFS hazard ratios were 0.3 0.35 or 0.3
or something,
and 0.53 I think in the darolutamide study. So quite similar efficacy results.
Which you would expect, right? I mean, to me, that's not at all surprising.
And is that a big trial result for you, or is it just a bit like the frontline clear cell renal cancer, where we've got the series of very similar drugs coming out with very similar? I get the impression
the prostate my feelings a little bit. I think it's big. Listen, more options are good. Better tolerated drugs, you know, and I think.
Do you think it is better tolerated? Because we showed, again, in our Uromigos meeting, we showed that French study where the patient preference study, remember that Pisces study years ago? And that, although there was an 8% preference, I think it was 40 versus 48. It wasn't a complete...
Wasn't huge.
It wasn't a home run.
It wasn't I think, much like we talked about Cabo and bone mets, there's a thing to a reputation of a drug, right? There's the data, and then there's sort of that reputation. There's also the clinical feel. Like the way we report toxicity doesn't capture what happens in the clinic to patients, right? It's overlapping, but it's not identical. So I do feel it's better tolerated. You know, I probably have used more Abby and Enza certainly than Daro, but I do feel it's better tolerated. And so I think...
Why not? Okay.
Yeah, I don't know. You know, some of it's just habit, right?
In the Uromigos voting part of that discussion, it was like
90%.
It was, you know, so the community feels strongly it's the best tolerated drug.
Right.
Chris Sweeney and I chatted around this, and he said it's probably more nuanced than that. And I think when the herd moves, I think that was Boris Johnson said that. But I'm not a great fan of Boris Johnson. I mean, I'll say it on my podcast. I probably am. I think, you know.
So we'll see how it impacts clinical practice, right? You know, but important data had obviously been developed in other settings first. You know, so there is experience with the drug. It's not a new drug, right? It's just a new setting.
Let's take this opportunity to move to lutetium, because now we talked about, we haven't talked much about lutetium so far, but there was lutetium studies looking at it after chemotherapy with vision, and then PSMA4, which is before chemotherapy, which showed PFS advantage but no OS, and we saw updated OS where originally the hazard ratio was 1.12. We made podcasts being concerned, and now it's actually matured a bit, and it's 0.9 something. But you know, there is this debate about whether you have to give it early or whether you can give it post chemotherapy. You and I have chatted about this before. You've said to me, look, it's quite well tolerated and it's easier to give it beforehand. I'm not sure everyone agrees with you on that. But there was a study at ESMO looking at first line, small randomized phase 2 out of Australia. A great study, I think, in my opinion.
Upfront PSMA. You didn't love the name.
But none of these studies are inspired, are they? I mean, look, Sunny Forecast. We'll talk about that in a second. Yeah. But that's a name.
That's a name. I agree.
And Niagara is a name. Would you agree with that?
I would agree. Yes.
I mean, even Arches is not too bad. But, you know,
we should do a top 10 names of trials podcast.
Why don't we do a podcast, the top 10? I actually like that idea. That is a good idea.
Third good idea.
And what we could do is you could come with 5, I could have 5, and we could then do that and then have a Twitter poll to work out who came with the best 5.
I think that's a good idea.
And I think if you both come up with the same one, it doesn't count, it goes into the bin.
Fair.
You know what I mean? So it's the ones that we don't have are both the same.
What were we talking about? Oh yeah, upfront PSMA.
Yes,
Arun Assad did a podcast with us. And so this was, the Australian group's done a great job of these investigator-initiated randomized phase 2s. They did therapy and enzalutamide. I think this is the third in the group. They've been heavily involved in development of radioligands. So this was...
a brilliant investigator group.
Yep, metastatic hormone-sensitive disease. They were largely, I think, or the majority of PSMA PET-positive lesions. They also did FDG PET. And they had high volume disease because it was docetaxel based.
It was quite complicated. I mean,
it was a bit complicated, yes.
And it was, I think in our podcast, it came back to the issue where you could today design it differently. And I think we agreed on that. That doesn't mean it's a brilliant trial. There's never been an investigated trial where you wouldn't say, I'd do it a bit differently.
Right. Practical decisions in IIT.
Number of cycles given was relatively small.
It was 2 cycles of lutetium PSMA, then docetaxel or docetaxel. They looked at PSA response at 48 weeks, or undetectable rate at 48 weeks. Which was
very impressive results.
Which was like tripled, I believe, 40-something to 60%.
And it wasn't powered for PFS or OS, and I wouldn't get too excited about that personally.
Yeah, you know, randomized phase 2, so all the caveats. But I think it showed it's safe to give this drug up front, and there's a big study called PSMA Addition. That should be the definitive study of that. But it was safe. It led to PSA declines. And again, I think it just adds to the body of evidence that, you know, state the obvious, this is an active drug. And with active drugs, we should move them up front. Right? We shouldn't save them because a lot of patients won't make it.
Some people said to me that there were 2 other big randomized phase 3 studies presented at, there was the STAMPEDE arm at ESMO, there was a STAMPEDE arm and the PATCH trial, both out of the UK. So I'm going to give a quick flag wave, if I may, and investigator-initiated randomized phase 3s. So it is worthwhile talking about that. And the metformin study, I don't think it showed an efficacy difference.
Correct.
There was an issue around this high-risk subgroup of patients.
High volume,
High volume. I'm not super, it's a subgroup and there'll always be a subgroup.
I don't understand it biologically. I think subgroups can be valuable if biologically, excuse me, it makes sense. But if you just sort of pluck, and I'm not saying they did this, but if you just look at one subgroup, I don't know what to do with that. I think the most impressive results were the cardiovascular effects. There was an A1C lowering, I think an LDL or some cholesterol panel lowering.
Yes.
You know, so that's an issue for these patients, right?
Long-term cardiovascular, and we chatted to Silky around this, and you know the 5 or 10 year cardiovascular tox data from that, as patients live longer with prostate cancer, it's going to be incredibly informative because it would have wider implications. And if you end up, or you might end up, you know, really having in the future, dare I say it, curing prostate cancer and making patients live 10, 15 years, then...
I mean, like germ cell, like we deal with those issues.
Then cardiovascular protective health then becomes a 10 out of 10
Do you think people will use, I mean, I guess in my practice...
They might not use it today, but they'll look at
I don't think I would use it broadly, but it reinforces that, which is true for you and me. We need to get our cardiovascular fitness in order, right? Maybe more true for you than me, but we need to get...
Well, I don't know if that's a fair comment to comment on my cardiovascular. I actually feel quite happy while walking up hills.
You know, we need to, if these are 60, 70-year-old men that we, and I say this to patients, sometimes when patients, especially in the adjuvant setting, they've had a cancer, it's consumed their life appropriately, and now we're 2-3 years out and they're probably cured. I say, hey, listen, don't forget about all the other things that us, you know, in my case, middle-aged men worry about, right? Cholesterol and da-da-da, and hypertension, we can't forget about that just because you've had a cancer diagnosis. To me, this is a reminder of that.
And the patch study, again, was looking at estradiol patches versus LHRH agonists, and it was looking at things like bone health and other, and that also showed potentially better tolerated potential benefits. So I think those 2 studies, it's worth giving a shout out to. I think when people do big randomized phase 3 investigator-initiated trials, it does have, you know, it should have.
For sure. I mean, Stampede's been an amazing effort. Kudos to all those investigators. We've had Nick James on the show. 12,000 patients I learned at the Uromigos Cup.
We should get him back on the show.
For sure.
There was bladder cancer at ESMO too. Actually, it was a good bladder cancer at ESMO, not just because of the NIAGARA data, which I was lucky to be involved with. The first perioperative trial, neoadjuvant adjuvant report, we've done a podcast on that. I think it was our most popular podcast of the year so far with Petros. I did it in a car park.
We did it, we were actually at ESMO doing it.
And the story there is that durvalumab, given in combination with chemotherapy, surgery, and then adjuvant durvalumab versus neoadjuvant chemotherapy alone and surgery, associated with an EFS, an event-free survival hazard ratio 0.68 and 25% reduction in the risk of death, no increased surgical complications, and it was quite straightforward. Coming back to that principle, and we talked about this at the Uromigos meeting in a lot of detail about, you know, it's giving earlier immune therapies better than waiting till you've had surgery and then all the problems and complications and then giving late immune therapy. I think people in future generations will look back on urothelial cancer and say, as soon as you've got a problem with urothelial cancer, getting the immune therapy in early is important. Now, whether that's with platinum-based chemotherapy and durvalumab or EV pembro or EV durvalumab or disitamab, that will sort out in the future. But I think this is a change because, in my opinion, it changed the focus away from the surgery, potentially, to saying, can we begin to cure these patients, 10% bounce in PATH-TR as well, can we cure these patients with systemic therapy? And during the rest of the meeting, there was a long discussion about bladder-sparing approaches. And I think NIAGARA prompted that. The other bit of data that prompted that discussion was, I think, Jonathan Rosenberg showed the 5-year update for EV pembro with a 40% 5-year survival in GEM carbo patients. Now we go to Maria DeSantis' trial back in the day, the URTC study, it was basically 0%. Now, you know, there are lots of issues around.
But still it's an impressive number.
Well, yeah, let's call it 5% versus 40 and 8-fold. Now, if you can translate that into the neoadjuvant setting, you might end up really start curing this disease.
I think to me what I took home is, as you said, we now have so many active drugs in bladder cancer and combinations, you know, immune therapy based and ADCs, et cetera, that we're about to enter an era where we're going to give a whole lot more active drugs perioperatively. We're going to look at contribution of components. And there's going to be a whole lot less patients going to cystectomy, I suspect. and they're gonna get this therapy. They're gonna get assessed for I guess not path CR, but they're gonna get assessed for clinical CR, and then maybe there's some bladder approaches. Maybe it's a pretzel. Maybe, I don't know. There's gonna be something where we say, let's keep the bladder. Yeah, we need to watch it and manage it and but we don't need to cut it out, right? And the urologist listening will maybe shriek. Dan Barocas was at our meeting. He's one of the Vanderbilt urologists and was saying, hey, wait a minute, cystectomy is still a curative operation. And I don't disagree, but in terms of what patients don't want, they don't want cystectomy, right? You've never had a patient who said, hey, doc, I really love this cystectomy. I love this bag or whatever.
And coming back to that Shaw trial with neoadjuvant sacituzumab, clearly what the Italian group was doing was saying to patients, look, we're seeing quite a lot of path CRs here. And the patients were saying, well, if you've got path CR, let's just check before. Yeah. And then you get the cystoscopy in the urine out, and they're like, you know what, you're there. And I'm not having the surgery.
Yeah. And you got the ctDNA in there, that's useful. Yeah.
And as soon as that process starts, it's going to be difficult to stop that.
Yes, agreed.
And nothing changes until everything changes.
Yeah.
And
very profound.
And I think there is a chance that we'll look back on that moment.
And honestly, I don't know that urologists love doing cystectomies, right? Yeah. It's a big, complicated operation. Dan was telling me, it's like the gift that keeps on giving. It's not so much the operation; it's the complications for the next weeks and months, and obviously, moreover on patients, right, and their altered anatomy and lifestyle, et cetera. So
when you see a patient and they've come back from the surgery and you said there was no cancer left behind, they don't say fabulous. The first thing my patients tend to say to me is, did I need to have the surgery?
Oh, is that right? Yeah.
Yeah, because there's no cancer left behind the surgery. So, why did we do it? Oh, really? Oh, I'm thinking great news. And they're thinking, oh, really? I put this,
yeah, so I think not next year, but in 5 years or something, we're going to look back. We're doing a whole lot less cystectomies. We're going to refine our tools for what is a clinical CR. Yeah. And do you need everything, or can you just do, a few of these things? And maybe maybe MRI is the best tool. Maybe it's ctDNA. Maybe you have to do a combo, but that's going to be an area of active investigation.
I'd like to talk about the next generation of ADCs during the concept of our Uromigos meeting. So we're going to talk about that in a second. Okay. And I'd also like to talk about sequencing immune checkpoint inhibition then. But I would, before we get to that, I'd like to just talk about, let's do the Sunrise program, talk about good names of clinical trials.
Yeah, that's a good one.
Sunrise 1, 2, 3, 4, and 5. We saw data from Sunrise 1 and we saw Sunrise 4 data at ESMO. Sunrise 1 was the non-muscle invasive data, and that was where we looked at citrilimab and TAR-200 plus citrilimab, and you saw a bounce with a combination.
And TAR-200 gemcitabine-eluting pretzel, sort of this device that gets put in the bladder, yeah.
And I think this drug is transformative in non-muscle invasive bladder cancer associated with, as a single agent, with high path CR rates in combination with citrilimab. And I think there are multiple cohorts in Sunrise 1. Yeah. And I think TAR-200 is transformative in that early setting in non-muscle invasive disease. And my feeling is that gemcitabine is an active drug, but the way we were giving it previously, of it just inserting it, rolling around and peeing it out, not very scientific.
Right.
And the same applies with BCG, by the way.
Yeah, exactly.
But this appears to be much more, it's a more thoughtful approach, a slow release, and I think it's going to be transformative, as I said before. Agreed. We also saw data from Sunrise 4, where we saw, again, the combination with citrilimab versus citrilimab alone, and a bounce with the combination. So higher response rates with the combination. And my take on that is that in muscle invasive disease, the role is more complicated.
I agree. Because what patients die from muscle invasive disease is micrometastatic recurrence, et cetera, not an in-bladder recurrence. So I think that device is going to be most useful in the non-muscle invasive setting. And as mentioned, maybe it's after neoadjuvant therapy and you don't want to do cystectomy and there's some role for that. I don't know, you have to sort of figure that out a little bit, but it has clear activity. It's a novel delivery method. They've done a great job of developing it across now 5 trials, large trials, and a lot of different arms. I thought they've been thoughtful about that approach. And there's other drugs you can put in there. It's not just gemcitabine. So I think we're going to be seeing a lot more of that moving forward.